Hello, Mike from Perseus here. I just wanted to take a minute today to share a little bit about a new tool that we just released. It's still in beta and has some sharp corners to it, probably some broken components, but hoping to build it out in the near future if there's interest outside of our own organization. So this tool is about New York State's external appeal database, which is shown on the screen here. This is a database of external appeals, that's independent medical reviews, the sort of first independent level of appeal available to most folks when they receive health insurance denials in the state. So this is a dashboard that's pretty cool and super useful and relatively unique in terms of existing. Most states don't have such a publicly available database. It's maintained by the Department of Financial Services in New York, so kudos to them and their team and all involved in maintaining and getting this dashboard released initially and then maintained since. So what is it? This is a dashboard that, as I said, has these individual case records corresponding to external appeals of health insurance denials. And for those who aren't familiar, why would we care about documenting external appeals in particular, and what's the deal with external appeals? Well, typically when people face health insurance denials, they have access to, as a patient, various forms of appeal to challenge the denial if they think it was wrongful, or if their physician thinks it was wrongful. And typically the first level of appeal people have access to is one that's quote-unquote internal in their plan. So this means that they're basically responding to the same entity that made the determination, the insurer, the insurance administrator, saying, I think you got this wrong, here's why, you said it wasn't medically necessary, purportedly, here's some evidence that suggests otherwise, etc. And then that same entity either tasks an employee at that entity or hires an independent contractor to review the case and make a new determination about whether or not the initial denial was appropriate. So you may have gathered in that description that there's something very wrong potentially, some potential for some real conflict of interest there, which is that the insurer or the insurance administrator that issued the initial denial and which has a clear financial interest in preferring one decision over the other, namely if they don't have to pay for the service in question, they come out ahead monetarily, is actually in charge of managing this process of dictating to an employee that they need to make this review and how they should go about doing that review of the appeal, or in contracting some third party, they still have influence over that process and who they hire or who they contract. So to address that, or to partially address that, a mechanism exists in most health insurance markets in some form or another of challenging that internal appeal if it ends up not going in the favor of the patient. So you can, once again, in certain contexts, if it's for medical necessity, for example, in most contexts, you can request that the appeal gets re-reviewed at a second or external or independent level. And this second level is really important because it's actually reviewed by independent third parties that are often arranged either by some regulatory agency that's involved in the type of health insurance for which the appeal is being sought, or sometimes they're sort of rooted through the insurers, but they're still rooted to independent third parties. They have no financial interest, these third parties, in preferring one decision over the other, at least none so direct as the initial adjudicating entities, and they get audited, and their data is sometimes made public, but always evaluated by regulators and third parties who are sort of monitoring what's going on. So these third parties, you can see some of them here on the right, iPro, MCMC, what they're calling the appeal agent here. these third parties are meant to be more independent and less biased, and the decisions they make are binding on the health plans. So if they overturn a decision, the health plan has to cover what they overturned. If they uphold it, the health plan's allowed to stick with their denial. So these are really useful outcomes to look at because, at least in my view, they provide a much better proxy for the ground truth appropriateness of an initial denial. They're not perfect. They have their own biases baked in. They're humans, of course, actually doing the decisions, so they make mistakes. All that sort of stuff still goes on, but they're not making more money if they're choosing to uphold a denial, at least not on the face of it. If there's other things going on behind the scenes, that's more complicated, but the clear financial incentive is missing, which is good. And as a result, because their decisions are a sort of better proxy than internal appeals or initial denials for the appropriateness of the initial coverage requests, it's really interesting and useful to look at the rate at which these third parties are finding things merit overturn. And as will be no surprise to anyone who spends a lot of time thinking about health insurance denials, the overturn rates are really staggering in a lot of contexts, and suggest a lot of troubling things are going on. In particular, that internal appeal adjudication is not doing what it's supposed to do in many contexts. So that's, I think, why the data is very interesting and important. What is this dashboard all about? So this dashboard, again, has these individual cases. For each case, the state, you can see, sort of provides some metadata about the situation, the sort of high-level diagnosis category, the high-level treatment category associated with the situation, the health plan involved, the decision of the reviewer, third-party reviewer, the type of appeal, so what was the grounds for the appeal or the grounds for the initial denial, purportedly, medical necessity in this case, the insurance type, so there's a bunch of different insurance types in this data, a lot of commercial stuff, Medicaid managed care, indemnity plans as well, CHIP. And then some other demographic data, gender, age range, decision year, and again, this appeal agent. So that's all well and good. Something to note is that this diagnosis category and treatment category, I think, are really interesting because you can sort of look through the data and try to understand to what extent not only are external appeals, being overturned at very high rates in general, which is problematic in general, but the extent to which they're high is highly dependent on the type of care being sought. And some types of care, some categories of diagnosis or treatment for which people are seeking external appeals are overturned at just staggeringly high rates compared to averages, which again suggests that those types of care and treatments are potentially being wrongfully denied at disproportionate rates. So there's some inequity in how the harms are distributed of the wrongful denials. Another thing that's really interesting about these individual cases in this data that makes it really rich is that in addition to all of this metadata, which is sort of good to get a high-level understanding about how the cases are distributed, each case actually has a plain text summary written by physician reviewers from the independent review entities describing the context surrounding the case, what their decision was, why they made their decision, whether or not they thought the health plan acted reasonably and with sound medical judgment, all sorts of details about their determination, which are really interesting. And then they also contain, each of these cases, a sort of list of references. Not all of them do, most of them seem to, but they have references to the sorts of literature that the physician reviewers relied on or cited in their responses. So this is the dashboard that already exists. It's existed for a long time. For some reason, it's really understudied, in my opinion, and not talked about nearly as much as it ought to be in discussions of wrongful health insurance denials in the media. But kudos to the people who really advocated hard to make this a reality and use it to help monitor what's going on. But so this has existed for quite a while. It's relatively understudied, and as someone who's used it quite heavily over the years to understand, help understand our casework and the sorts of appeals we work on and what sorts of harmful trends are most prevalent, there's some things in the dashboard that aren't in the dashboard which I've long wished were in the dashboard, and which I think could be really useful to a lot of folks. So the way we get around that when we're working with this data is we just download all the data. You can, they have this nice export feature. You can just download a CSV of all of this data and do whatever you want with it. So that's what we do. We download it and then we write some code to help us analyze it and do whatever we want with it. But I return to it so often, just trying to do something real quick where, I'm talking to someone and I say, oh, that's interesting. Talking to some foundation or something that focuses on a particular type of care, and I think, I've never actually looked at the extent to which external appeal overturn rates are really problematic for leukemia or some specific thing that I just haven't happened to look into. And so what I end up doing in those situations is, I come back to the dashboard, I re-download if I want a fresh copy of the data with some more records, and then I write a little ad hoc script or a little ad hoc user interface to do something and investigate something real quick, and then I move on with my life. But I've thought, I do that so often, and I talk to so many people who are very interested in this data but aren't familiar with it, that I thought it would be really nice if those sorts of analyses could be done by anyone easily without having to code. And of course that's not possible if you want a lot of control over the sorts of analyses you do, but I think there's some basic analyses that most people would agree are useful that aren't currently present in the dashboard. And so what we're releasing is just a little UI that has a complementary set of functionality to the dashboard that you see here. So I'll show you the dashboard in a second. We can just quickly go through it. But I hope you'll check it out. I hope you'll leave feedback if it's useful, if it's not useful, if you think a feature would make it useful that's not currently implemented. Any feedback would be great. But we're just really hoping that it is something that can make this data more accessible to more people, and by allowing more people to use and interact with and monitor this data, especially on the regulatory side in terms of monitoring, the hope is that there'll be more accountability and more oversight for the types of concerning behavior that I think is pretty evident in this data. So before jumping into our dashboard, which I'll show you in a second, let me just highlight some features of this dashboard to outline what's not here, which we've added, which is hopefully useful. You can do a plain text search on the summary text. I think it's only on the summary text. It might also search metadata that I'm not sure about. But you can do a plain text search that at least includes the summaries without references, and get a filter set. So I could, for example, search for leukemia here. And if I do that, I'm left with only 174 records out of the 40,000 or whatever it was. And now I could go through and I could try to understand things about the cases that pertain to leukemia potentially. And that's really useful, I think, for people who are, working with certain patient populations, or advocates who are focused on certain types of care, or regulators who receive complaints or concerning allegations about wrongful behavior of health insurers for certain types of care. By inspecting the data in a limited way as it pertains to that type of care, one might be able to learn some things. So that's useful, I think. But a major limitation that I've found in working with this data over the last few years of this plain text search in this particular application that I've described of trying to look for certain types of care or services is that the plain text search is just that. It's just a search, a direct match, or maybe fuzzy match, I'm not sure, but some sort of match on the search term. And what that means is that the cases that we filtered for, these 174 cases, while they're guaranteed, as long as this implementation is not faulty, to relate to the term leukemia in some way, there's no suggestion here, and I don't think it's the case, as I'll demonstrate in a minute, that every single case that we filtered for is an appeal for which the appeal is specifically about a service related to the treatment of leukemia. And that's really what we typically want when we're trying to do this sort of search. We don't want all cases that just mention the term leukemia. We want the cases that are specifically about leukemia-related care or services. So in these first few cases, when we filter for leukemia, the diagnosis category in the first case is cancer. But okay, this third one is actually the diagnosis in question seems to be about the respiratory system. So let's see what that looks like. In this case, it says the diagnosis is actually an asthma issue, which is under review in this appeal, and an inpatient admission that's related. And now let's see where leukemia is mentioned. So inpatient admission is not medically necessary. At time of the admission, patient was hemodynamically stable, not in any respiratory distress, wheezing, okay. The blood work revealed leukocytosis thought to be due to past medical history of CML. Okay, so there's a past medical history of leukemia. Okay, and then asthma exacerbation improved. Leukocytosis thought to be due to the leukemia. Patient discharged home. Patient symptoms started to improve. Okay, so there's some decision here, but so hopefully you see the point here. I'm not a medical doctor, and I'm not qualified to determine from what I just read, actually, whether or not from what's said, the sort of suggestion is that the asthma issue and the inpatient admission is related to this past diagnosis and past medical history and this leukocytosis, or if instead they're saying that the blood work revealed this thing, but this thing is actually an independent issue due to the past leukemia. So I don't know which of those two is true. If you're a physician, feel free to leave a comment educating me about that. That'd be interesting. But regardless, I think you can see the problem here, which is that in principle, certainly this plain text search could have revealed a situation like that, where some completely irrelevant past medical term showed up based on the plain text review, but in fact had nothing to do with the specific appeal under consideration here, which in this case was upheld. So that can and does occur. I probably should have prepared an example in advance that actually definitively had this situation, but I can tell you from years of looking at it, that situation does occur. And so this plain text search doesn't do exactly what at least I would hope it could do in isolating appeals that really pertain to a particular diagnosis, at least through this search. So that's a feature I've always wished this had, and that's a feature that we tried to implement in the dashboard, which I'll show you. It's not perfect, but I think it gets closer than this search. Another thing to note is that there are these diagnosis and treatment categories on the left, so you might say, like, wait a second, why are you talking about trying to isolate cases that pertain to a diagnosis when in fact there's metadata specifically for that purpose that presumably does it perfectly. And the problem here is that while this metadata is very useful for understanding the categorization according to these categories are pretty broad, and generally when we're using this data, we're interested in more granular understanding of how appeal outcomes are varying based on diagnosis. So you can see here, for example, autism spectrum disorder is labeled, which is pretty specific, but then there's a lot more broad categories. There's cancer, for example, but there's no leukemia. So we couldn't understand something specific to leukemia from this breakdown. So that's the main point of that diagnosis part I just mentioned. Another thing we do really often that's not technically a feature in this existing dashboard, but which is you can kind of do through a hacky mechanism, is just understanding appeal overturn rates. So one can kind of do that in a hacky way, which is that the appeal decision counts are labeled on the left-hand side. So without writing any computer software or anything like that, you can just, or downloading the Excel file, you can just sort of, count up the total counts here, and you can see, okay, wait, there's 17,000 overturned cases, and then another 22,700 overturned in part or upheld cases. So the complete overturn rate in this data in total is the 17K over the sum. Okay, so you could pull out your calculator or Excel sheet and do that and get the overturn rate. And then you might want to know, like, wait a second, but what is the overturn rate specifically for diagnoses, appeals that relate to diagnoses of cancer? So you can sort of click on the cancer diagnosis here, and then conveniently the appeal decisions do update with the counts, so that's good. This is something we do all the time. We have like a little internal tool to do this without using this dashboard with a script. But if you're not someone who wants to do that and download this data, or is not going to do that, it would be nice if you could sort of use the UI to do that directly. So I think those are the main things. And with that, I'll just quickly demo the dashboard itself, as you can see what's different. So here's the URL for the dashboard. I'll link it. So when you go to the dashboard, there's a little loading screen with some basic information about the dashboard, and then you can just move ahead when you want. And if you do this on the first time coming to the page, you might see a loading screen like that. Here, let me clear the cache and reload it so you can see what I mean. So when you first come to the page, you might be like, all right, skip the words, let's go to the tool. And if you do, you'll actually be told to wait. And that's because it just takes some time to download this data to your computer. We download it so that the interactions are kind of quick and snappy. So once it loads, you'll come into this page. There's a bunch of text matter around, sort of guidance to try to help people understand what this is all about. If you find that annoying and you already know what this data is and you just want to use the tool, you can just turn off all that front matter on the top here. And what you'll see is basically it's pretty similar to the other dashboard in the sense that you can get total counts, you can get the overturn rates we just display now, rather than having to calculate them from those overturn counts. And then we display some other stuff based on the filter set that you've specified. So which years are involved in what you're looking at, what's the most common diagnosis among the appeals that you're looking at in your filter set, what's the most common extracted diagnosis, which I'll get into in a minute, etc. So if we come back up here, these filters, some of them are just exactly what you saw in the actual dashboard, so no new functionality there. And the main new thing here is that we used some machine learning to try to extract from each appeal case the actual diagnosis that was the specific actual diagnosis and specific service or treatment that was actually the service and the associated diagnosis that was in question in the appeal. So these are not perfect. These are extracted by us with some machine learning that we performed. So you may notice some mistakes, but we tried to do this in a way that allows you to understand whether or not there are mistakes, which I'll get into in a minute. So if you look at this dropdown, you'll see there's now sort of specific diagnoses, specific, not super specific in all cases. There's still larger categories, but rather than, for example, cancer, we should have sort of specific types of cancer, colon cancer, for example. So there's that. Let me look at one with a little bit more volume. So the next part makes a little more sense. So let's go to, I guess, Crohn's disease. That's something I'm familiar with, and I know there's a lot of cases here. So for Crohn's disease, we can see there's about 500-ish cases, a pretty high overturn rate, very concerning, 73%. Again, you can see the sort of most common diagnosis category and treatment category. These aren't very interesting because we've selected a specific diagnosis, so no surprise the associated most common category is probably just this one for every single case, which is digestive system. But maybe a little more interesting, among all of these Crohn's disease cases, the most common treatment at question in the appeals is evidently Stelara, so that's the most common thing that's being denied here and then overturned quite frequently. And you can sort of scroll down and see how that 73% arises for full overturns and partial overturns and what the counts are for each of those. And then I think something that's perhaps most different than the dashboard that's maintained by DFS is that we have this sort of exploratory section. And the motivation here is a lot of times in the past we've been interested in understanding, what types of cases in New York and across the country are being not only wrongfully denied initially, but also wrongfully adjudicated at the level of internal appeal, and then overturned sort of at high rates on external appeal. And how do those cases relate? Are they, is each one a snowflake and they're all different, and it's hard to see patterns, and despite this pattern of wrongful denials being prevalent, it's not systematic or systemic, or in fact is something very different happening, and there's like huge volumes of very specific singular types of cases for which despite large volumes of appeals, despite large volumes of appeal overturns on independent review, are just perpetually being administered wrongfully over and over again to the same patient populations who are experiencing the harms that result from those delays and denials that aren't appealed. And so that's a pretty hard problem. I think there's lots of people working on it. There's lots of great investigative journalism and other analyses out there that you should certainly look at. But I think something that can be really useful here is building tools to detect these patterns, and to do that, I think you need to be able to explore the data in ways that don't just involve sort of looking at overall numbers or rates, and also don't just involve individually going through cases one at a time, because that's laborious and can't really be scaled. So here what we have anyway is, that motivation aside, is about 2,000 records out of the 46,000, just so that your browser memory doesn't blow up. And these records are clustered in 2 dimensions, sort of laid out, and the axes here don't mean anything except for similarity. So we use some popular algorithm called t-SNE to sort of arrange different cases, different subsets of these 2,000 cases on the 2-dimensional plane in such a way where points that are closer together are more similar by the judgment of our machine learning embeddings than cases which are further apart. So that's not perfect, that notion of similarity, but hopefully there are some patterns in the data that this might reveal, and as we improve embeddings, maybe that'll get a little bit better. So you can sort of scroll over these individual cases, and for each one you can read all of the metadata associated with it, and you can also, if you click on it, get an expanded view with all of that metadata, the raw metadata, as well as this metadata that we actually extracted that may be erroneous again, so you should verify that. And in the case of our extracted data that may be erroneous, we underline it with a color. So you can see chest pain here is what we claim to be the sort of relevant diagnosis for the appeal, even though the official data only said cardiac, circulatory, or digestive gastrointestinal. And then if you go look at the raw summary, we'll sort of put corresponding underlines, highlighted underlines, in the raw text that's in the raw data to show you where we extracted that term from. So in this case, actually, the review agent explicitly said that the diagnosis in question was chest pain, and so we underline it with the same color. That's where we got it from in this case. So you can sort of verify that in this case it looks like, okay, we did a good job. The reviewer themselves said that this was the diagnosis in question, and then they later sort of go on to repeat that she was hospitalized for chest pain. Yeah, so you can sort of look at these cases, and the thing that we hope to be interesting here, especially as we start to improve the embeddings that are responsible for this particular arrangement in 2 dimensions of these points, is that there may be clusters. So for example, we colored all these points blue over here because we think they're sort of similar in some way. And we think there may be clusters that the contexts are similar around the denials, the contexts are similar around the evidence pertaining to the appeal, and then if we find a cluster like that where all of the contexts are extremely similar, and then all of the overturns or all the decisions are overturns, that suggests something very wrong is going on, because there's this high external appeal overturn rate for cases that are similar, despite the fact that each internal appeal review is supposed to be, honestly and genuinely reviewed by humans who are thinking about the specific circumstances of the case. And moreover, the insurers are learning in real time, as cases are appealed to independent medical review, about the decisions of the independent medical reviewers who are overturning cases. So there's little rationale that's reasonable that I can understand for why certain types of care should be repeatedly and perpetually over many years resulting in high levels of external appeal overturn. That seems inexcusable to me. It seems like something that should be addressable. It seems like something regulators should be able to act on, and I think they're interested in doing that, frankly, but I think they just need the resources and funding to be equipped to take that sort of action. Anyway, I'll get off my soapbox for a second. So if we look at this cluster in the top right, just to hammer the point home, and we sort of scroll through these cases, hopefully if our embeddings are any good and this visualization is any good, they should have some relationship, or at least be more similar than cases that are all the way across the map from each other. So if I scroll through some of these, let's see, they actually don't look very similar here in diagnosis, but then we can see, I think it's the treatment that is resulting in all of these contexts being deemed similar. So you can see there's consumer-directed personal assistance program services, and that's sort of corroborated in this case, you can see on the bottom, by the actual review summary. And I saw that in quite a few as we scrolled over them. Yep, CDPAP, yep. So all these cases are similar in that sense, I guess. And they might be similar in a broader sense, or in more senses if we actually clicked on the review summaries and understood them. Let's see. I'm not sure. This might be personal care over here. I've seen quite a bit of personal care. And if we go across, probably when we just click randomly, we're not going to start seeing CDPAP all over the place. Yep, I'm not seeing any over here, whereas the rate was, very high over here, right? All of these look like they're CDPAP. So that's the idea. You can sort of use these visualizations, hopefully, especially as we improve them, to investigate pockets of this data that maybe are interesting to you. And again, if you go up to these filter sets and say, actually, I'm not interested myself, based on my work, in all of these appeals, I'm interested specifically only in Crohn's disease. Maybe that is true if you work for an advocacy organization that's focused on Crohn's disease, for example. Well, you can do that filtering, and now the visualization is only showing cases with that extracted diagnosis. So you can do the same sort of investigation of pockets. And the real last thing I'll say about this visualization that I think makes it useful, that maybe it's not so useful without, is that you can change the coloring so that it's actually colored by appeal outcome rather than cluster. So the green here represents overturned in some form, pink or whatever that color is upheld. And so now you can start looking for, can I find pockets of similar cases that are both extremely similar and like overwhelmingly pink or overwhelmingly green. The overwhelmingly green case being the very concerning case. So maybe you find like a pocket here of, for example, cases that are only related or all related to Stelara, and they're overturned at like 95% rate. I'm just making that up. I'm not sure what the case is. You have to look. But that would be interesting and useful, I think, for hopefully regulators and advocates and patients themselves working on their own appeals. So that's the idea. That's basically the dashboard. There's a little bit more down at the bottom. You can, if you're sort of generally interested in this data and you don't have a very specific use case, you can turn off all filter sets, and then these bottom cards are maybe a little bit useful. I certainly find them interesting. So for example, this bottom left card is the extracted diagnoses, which again may be erroneous, take with a grain of salt, but the extracted diagnoses with the highest overturn rates. I think this is, to me, the most interesting card on this bottom section, because it shows types of diagnoses where the external appeal overturn rates are just insanely high, frankly. I mean, there's no explanation that's reasonable that I understand. Please feel free to educate me in the comments if you disagree, but I don't understand any reason why they should be occurring. I mean, Parkinson's disease, 78% overturn rate, it's insane. Alzheimer's, crossbite, presumably a lot of them cases corresponding to children on CHIP. Asthma, diabetic ketoacidosis, Crohn's disease, that's alcohol withdrawal. I mean, the consequences for patients in these situations can be extremely serious. So there's no reason these should be high. And just as a last aside, before I sign off, I'll just mention that they're not high when they're incentivized to not be high. So in Medicare, for example, Medicare Advantage, the average overturn rates on level 2 appeals, which is the equivalent of these external appeals in Medicare, is something like 5% on average. And that's where all these numbers ought to be, in my opinion. And that's no coincidence. In Medicare, there are financial incentives to ensure that plans aren't getting things wrong at the level of internal appeal this often. Plans get penalized if they're in the form of a star rating hit, if their appeal overturn rates are too high on external appeal, and moreover, all of the internal appeals are automatically forwarded, so if they're upheld. So there's no way for them to get out of that scrutiny, and they know they're going to be scrutinized, and lo and behold, you see the appeal overturn rates are like 5% on average. So my hope is regulators in New York will continue to monitor this data and continue to think about this data broken down by diagnosis categories and treatment categories, and try to focus on contexts that are extremely consequential and harmful for people, and make sure that these numbers in 3 years, if they're tracking this data, no longer show 78%, but show something much lower, hopefully like 3% or something like that. Yep, so that's really it. We'll release, or I guess I already put up a blog post just giving some more context for those who don't watch this video. And yeah, please let us know what you think, and thanks so much for watching. I hope you're all well.